Hello, everyone. Thanks for joining us for this Part B General Surgery Common Rejections and Denials. This is a webinar designed for those who submit claims on the CMS 1500 claim form or the 837P electronic form. My name is Mary Moko. I'm a specialist on the Provider Outreach and Education PO team at WPS GHA, and I will be your host today. Assisting me is my friend and colleague, Aline Sigler. We include this disclaimer in all our education, and we do so to remind learners that we made every effort to provide current information that is correct, but the information is subject to change. It is on the CMS website where you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. We will provide responses to questions based on the facts given. And finally, just a reminder that CMS prohibits recording of this presentation for profit-making purposes. So please, no screenshots or recording of our presentation. We do that for you and make it available on our website and our YouTube channel. Our agenda today reflects only the items that I plan to present now during this live education event. We ask that you carefully read the advertisements to reinforce the specific education that we will provide during our webinars. The topics that I advertised I would cover today are specific to Part B, Specialty 02 providers. That's general practice. Those who submit claims on the CMS 1500 claim form or the 837P professional electronic claim. So as advertised, what I'm going to cover in the next 60 minutes are Specialty 02, General Surgery, Common Rejections and Denials, how to fix and avoid both of those, and resources. And I think I misspoke a little bit earlier. I said general practice, but it is general surgery specialty 02 that I will be talking about today. Just earlier this week on Tuesday, I talked about general practice. But today's topics are common rejections and denials, and that's based on data that we've pulled, how to fix and avoid those, and resources. And I'll conclude with answers to questions if time allows such. To fully understand rejections and denials, it is important to recognize the path that a claim takes, or what we like to call the life of a claim. This is a simplified graphic on how a claim gets into our system. Of course, the provider would provide the service, submit the claim to WPS, then sometimes the system rejects those claims. We call those batch rejections. And when that happens, there are reports that are generated. You can see here on the slide the 277 or 999 report. So let's talk about this a little bit. Most providers submit claims electronically, and very few qualify for a waiver under a law that prohibits payment of services or supplies that a provider did not bill to Medicare electronically. Now, to confirm claim receipt, providers should use the 999 report. Use the 277 report that generates for more specific information. Our electronic data interchange, or EDI staff, does provide helpful information in the Medicare 276-277 companion guide. And this is a guide, and I've linked to it here on this slide and in your handout. This is a guide that will help clarify and further define the data content requirements for an electronic claim. Now, based on these reports, you will know if the batch is rejected and if you need to correct or resubmit. Now, here is a simplified graphic that shows what happens to a claim that Medicare deems as unprocessable. Again, the provider would perform the service and submit the claim to WPS GHA. But because the information on that claim is in an incorrect format, the remittance advice generates a response that that claim is rejected. Now, it's very, very important that you understand the difference between a rejection and a denial. I think oftentimes many of us use those words interchangeably, and we really shouldn't because they are really very different things. So let's talk about that. Here's a slide that shows you a side-by-side comparison of a rejection versus a denial. And even, I catch myself, even after many years at WPS or working for Medicare, I catch myself using these words interchangeably, and then I have to correct myself. So a rejection, as you can see on the left side here, is what CMS calls unprocessable. When a claim is rejected or claim line rejected, it is returned what we call on the front end before it's even really processed or actually adjudicated. A rejected claim means something's illogical, something's missing, something's incorrect, it's in an invalid format. Because the claim is really never adjudicated, there are no appeal rights. You need to fix it and resubmit it. Now, you will find on a rejected claim on that remittance advice, or the RA, sometimes we call it, a remittance advice remark code of MA130, and that means that your claim contains incomplete or invalid information. There's no appeal rights. You need to submit a new claim with the completed or corrected information. You will also find for a rejected claim on the remittance advice a CO16 group code, and that means it's a contractual obligation. The patient is not liable for payment until you submit a new claim and the services are indeed processed or adjudicated. A denial, on the other hand, is a claim that is adjudicated, and when something's denied, it means it fails to meet payment criteria. Now, that could be due to a law or what we call a statutory requirement. Perhaps there's a denial because the services did not meet medical necessity, and this would include any utilization parameters or frequency denials. There's also denials because of eligibility. There are appeal rights available for most denied service. There's just a couple of exceptions. One of them I'm going to talk about in a little while. But for a denied claim, most often, with few exceptions, you will find on the remittance advice the code MA01, and this provides the appeal rights to the provider, and the patient liability then is determined based on the denial and whether there is an appeal, and Medicare does determine that payment or partial payment can be made. So the code MA01 provides information about the right to appeal. Now this graphic shows then the path for a processed claim. Again, the provider would provide the service, submit the claim to WPS, and the claim or claim lines would either pay or deny, and the remittance advice is generated. I want to talk about that remittance advice just a little bit. Sometimes we call it the remittance notice. Sometimes you'll hear people just call it the RA. Most providers do receive an electronic remittance advice, or what we call an ERA, as opposed to the standard paper remittance, or SPR. Now, depending on how the claim is processed, that RA may include information about any adjustments made to the claim or denials. It could also include information about something that's missing. Sometimes it even provides notice about refunds and offsets. The ERA provides payment information about the transfer of funds and payment processing from the health plan to a healthcare provider's bank, or the explanation of benefits. The CMS Remittance Advice Overview booklet that CMS previously published is no longer available, but there is still a guide for Medicare providers, physicians, and billers to use. Instead of the booklet, CMS now includes the information about the electronic remittance advice on their website. And I'll have Aline place a link to the healthcare payment and remittance advice webpage in the chat. It is here that you can find the guide that includes things like introduction to the RA, components of it, how to read it, and even more. Now, codes on the remittance advice provide information about the claim. Claim adjustment reason codes. We call them CARCs, C-A-R-C-S. You can see here is the acronym used. These explain why a claim paid differently than it was billed. The remittance advice remark codes, or RARCs, RARCs, provide more details about an adjustment that's described by the claim adjustment reason codes. Another type of code, and one that I mentioned briefly already, is the group code. These convey the financial responsibility for any unpaid portion of the claim balance. A CO stands for contractual obligation. The provider is liable and can't bill the patient. And remember, it's that CO 16 that you're going to find on the RA for a rejected claim. And a PR means patient responsibility. The patient is financially responsible for those unpaid amounts. You can find code lists on the Washington Publishing Company's website. This company maintains the codes for CMS. We understand that some of the codes may be cryptic or maybe out of date, or the information they convey rather is out of date. And what I'm talking about here, for example, would be that some of those code messages may include an outdated acronym. For example, some of them may read um, something about a HICN, HICN. That's the health insurance claim number, and we know that that was replaced by the MBI, the Medicare Beneficiary Identifier, some time ago. However, again, we can't, WPSGHA can't change those descriptions or change those acronyms and descriptions. We can't make them more descriptive because it is the Washington Publishing Company that maintains those codes for CMS. Links to the code lists and the WPC, the Washington Publishing Company's website, is here. If you would like to contact the WPC for any reason to make a suggestion, you can do so by looking at that website that I've linked to here on this slide. It tells you how you can contact them. Now, after reviewing the remittance advice, you are going to need to choose the action that you need to take to fix the error, or resubmit the service, or submit an appeal. So for an unprocessable or rejected claim, you're going to need to fix it and resubmit it. If the claim or claim line denied, there could be multiple actions to choose from. You may be able to simply resubmit the service. You might be able to use a process called a clerical error reopening, or CER, C-E-R, to correct any clerical errors. And CMS defines clerical errors, including minor errors or omissions, as human or mechanical errors on the part of the party or the contractor. And I'll talk about the CER process a little bit later in this presentation. Another action to consider is an appeal. The remittance advice will provide appeal rights. Remember, it will be that MA130. I'll discuss appeals a bit later in this webinar. Registered users of our transactional portal can render a clerical error reopening or request an appeal using our portal. This is a self-service option. These self-service tools really do offer the most efficiencies. Our portal user manual provides illustrations and step-by-step instructions on how to use the portal features. If you've not already taken a look at that, I would highly recommend that you do so if you have any questions whatsoever about using the transactional portal. I'll provide for you a link to that a bit later in this program. Right now, though, I want to talk about whether you need to correct or appeal the MAC's decision to pay or deny a claim, or a claim line, of course. I talked just a couple of minutes ago about the clerical error reopening, or CER process. I told you I'd share more information about it. This is that process to correct those human or mechanical errors. Clerical errors or minor errors are limited to errors in form and content. and they do not include failure to bill for certain items or services. So examples of acceptable clerical error submissions could be mathematical or computational mistakes, perhaps transposed procedure or diagnosis codes, incorrect or inaccurate data entry, computer errors, or even misapplication of a fee schedule. So examples of these situations that cannot or can and those that cannot be processed as a clerical error reopening are included in a resource that I've linked to here on this slide. I just told you some examples of acceptable clerical error submissions, but there's also some good examples in that resource. The link is provided for you of those situations that cannot be processed as a clerical error reopening. Your handout includes that link as well as it's showing right now on this slide. You can use the portal for self-service uh, to render a clerical error reopening, or you can request a clerical error reopening via telephone or fax. And remember that that portal user manual does provide illustrations and instructions. Now, for claim denials, most often you can request an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. Physicians, suppliers, and beneficiaries all have the right to appeal claim determinations that are made by MACs. And for those of you unfamiliar with that acronym, MAC, it is Medicare Administrative Contractor, and WPSGHA is a MAC for Jurisdiction 5 and Jurisdiction 8 providers. The beneficiary or their representative can request an appeal on any service that's processed for them. However, providers or suppliers may appeal services for which they accepted assignment. However, for unassigned claims, the provider or supplier can act as a beneficiary representative, but only if the beneficiary signs an authorization statement. The form number is the CMS 1696, and it's called Appointment of Representative. In addition, providers and suppliers may request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or if the provider billed in excess of the limiting charge. And if that happens, the provider or supplier, of course, must refund any fees collected from the beneficiary. There are 5 levels of appeal, but only one level of appeal is rendered at the MAC. The first level of appeal is that redetermination, and that is the only level of appeal rendered by the MAC. Time frames apply to each of the 5 levels when submitting appeal. Additionally, there is a minimum amount in controversy that applies for level 3 and level 5 appeals. You can combine like denials or similarly denied claims on more than one claim in order to reach that minimum amount in controversy, or AIC. I've included here on this slide a couple of helpful resources for appeals. In addition to these, we of course have recordings out on our YouTube channel about the appeals process or how to appeal a claim determination. The first item here on this slide is a resource that's available on our website. It tells you how to appeal and where to send it and so on and so forth. And remember that self-service option is available to request an appeal. You do that in that transactional portal. The next resource that I've included here is just one of my personal favorites when I provide education to learners about the appeals process. I like to show this flow chart, this fee-for-service appeals process flow chart, available on the CMS website. It is updated annually. You have to be careful when a new year comes about, a new calendar year, because you have to give CMS time to update that flow chart, but they do update it on a yearly basis. And I like it because it shows all levels of appeal. It shows the time frames to submit your request, but it also shows the time frame that the contractor or entity has to render their determination, or their decision, I should say. It also has the amounts in controversy listed right there. It's just a real quick glance at a process that makes sense. It's one of my favorites, so I wanted to share it with you. All right, if you look back to the announcement or the advertisement for today's webinar, I mentioned that I'm going to cover rejections and denials and examples and those most common or those commonly rejected or denied claims for specialty 02, which is general surgery. Make sure I say that right this time, not general practice, but general surgery. So, and I have provided information to you today from what we call our data dashboard. So the data that I'm sharing today is all specialty 02 submitted claims for both jurisdiction 5 and jurisdiction 8. So that means the states of Iowa, Kansas, Missouri, and Nebraska, Indiana, and Michigan collectively. Those 6 states make up our MAC jurisdictions 5 and 8. And of course, today's presentation is part B focused, so it doesn't include those Part A providers in those other states. So only Part B, Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan today during this session. Now, while the dashboard does allow us to drill down by a specific state or states, and even counties, I pulled data for our entire jurisdiction. I just want to make that clear. So for those of you that may be wondering what specialty 02 is, specialty codes are 2-digit codes that are assigned to a provider when they enrolled. So during enrollment, providers do self-designate a specialty. While a provider can designate a secondary specialty, it is only that primary specialty, the one that's self-designated during enrollment, that is used during initial claim processing. There are some situations where a provider may request an appeal and stipulate their secondary specialty, and Medicare will then consider payment. But when claims are initially processed, the 2-digit specialty code connected to that PTAN, provider transaction access number, is what we're going to process the claims based on. The specialty code 02 is general surgery. I pulled data for claim submission dates September 1, 2023 through February 29th of 2024, and the data was last refreshed on March 13th. So what this means is that any claims submitted for this date range after March 13 for general surgery in jurisdictions 5 and jurisdiction 8 are not included. Our staff in our insight department, that's what they're called, they're our data informatics folks, actually update this data dashboard on a monthly basis. So the oldest drops off, we add another month to the data, and then of course they update that data refresh date. So here then are the top or most common rejections by reason for general surgery specialty claims in our jurisdictions. So the first one there is the claim lacks information needed for adjudication. There was 691 claims rejected, not denied, during the time frame for this data, this piece of data or this data chunk. This means that you need to check your claim to see what is missing so that we can adjudicate the claim. CMS provides, and I'll provide the link to this later when I talk about resources. They provide for you claim form instructions in one of their internet-only manuals. It's chapter 26 of publication 100-04, and again, it's listed later in your handout where you can find the claim form instructions. Another common rejection is that the rendering physician number is invalid and missing. So if I was a provider and I received notification on the remittance advice that a claim or claim line was denied because the rendering physician number was invalid or missing, I would make certain that if I did put it on the claim that I keyed it right, and I would also make certain that it is there if it is a service, and it indeed is. It requires the the rendering physician's number. So if it's missing altogether, you need to add it. Another common rejection is invalid or missing modifier, 428 of those. For this kind of rejection, I would, of course, look to the service that was rendered. I would check my documentation, see if a modifier is needed. I would check to see if I did report a modifier, if I keyed it wrong. If it's something that does require a modifier and it wasn't used to begin with, I might refer to the modifier fact sheets that are available on our website. Because those fact sheets list appropriate uses of modifiers and also lists inappropriate use of modifiers, it's good advice for use of modifiers and very, very helpful for these kinds of rejections. Another common rejection, missing, incomplete, invalid ordering primary identifier. So I would look to that place on the claim where this information is supposed to be entered. I would make certain that it was coded correctly, or if it wasn't there at all, I would make certain that I add it and I would resubmit that claim. Fix it, resubmit it. Next common rejection, claims must be submitted to the railroad board. This means that that patient, that beneficiary, is a railroad board retiree. The claim has to be submitted to that contractor. Next, top rejection or common rejection is place of service conflicts with the procedure code. Submit a new claim. You can call customer service and ask them this question: does your system accept place of service, fill in the blank, with CPT code, fill in the blank? What you can't do is call them and say, the patient came in on Monday, this happened, and can I use this place of service code with this CPT code? You can't provide a scenario, but you can ask them a straightforward, simple question: does your system accept this place of service with this CPT code? And they will answer it. Next is unable to obtain primary insurer information. That kind of turns a light on in my head to think that I need to go out and look at Medicare secondary payer information for this particular beneficiary's claim. Missing procedure modifier, again, going back to the one on the previous slide, I'm going to look at those modifier fact sheets. I'm going to look at the service, the code I reported. I'm going to look at the documentation and make certain that it is something that I would need the modifier for. So several things to consider. Patient name, insured, HICN, and name do not match. And this, folks, is exactly what I was talking about earlier when I said some of the reasons that print out on the remittance advice are cryptic or out of date. And this says HICN, and we don't really use HICN anymore. It's the MBI, but HICN still prints out as a rejection reason on the remittance advice. So for this one, you're going to need to take a look at your patient's Medicare card. Make certain that the name that's reported on the claim matches exactly. If there's a middle initial, you need to report it. Middle initial on the card, that is. The next one is this claim has been forwarded to Palmetto, which is the railroad board. Palmetto processes claims for railroad board retirees. And in this situation, the remittance advice is telling you that WPS already forwarded your information. And the reason for this, compared to this one here, claim must be submitted to the railroad board, is that for this rejection here, I'm going too far here. For this last bullet item here, this means that the supplemental insurer, or there's a trading partner agreement that says if this claim denies or rejects, you need to submit it to XYZ. And that's part of that trading partner agreement. So in this case, WPS has already forwarded the claim to the railroad board, so you need not do that. In the previous situation, on the previous slide, and you could see it in your handout, you need to do it yourself. The provider would need to submit that claim to the railroad board. Here then is also information we can pull from that data dashboard, and I do want to tell you, by the time I hit enter, everything comes back. All of this data comes back. It is just almost instantaneous, where we can see the top rejections and denials. In addition to the reasons, we can look at the top rejections by HCPCS or CPT code. I have listed them here. the top rejections by CPT code for specialty 02 general surgery claims. So you can see many of these are E&M codes, and the top right column here shows 36415, and that is the venipuncture code. I do want to tell you that venipunctures, if we're not going to pay for the lab, then we're also not going to pay for the venipuncture. So that may be a situation of why that one's showing up here as a top rejected claim. So if the lab was rejected, that means we're going to also reject the venipuncture if it was the only lab for that particular venipuncture code. So these are those top rejections. Just interesting to note. And then, of course, these numbers represent the number of rejections for the data that I pulled. Here are top denials by reason. Number one here, most common post-op care is included in the surgery. You may not bill the patient. 2,465. So these are situations for denials based on global surgery rules. There are a couple of encores in our or on our YouTube channel, and I'll have Elaine place the names of those for you into the chat. One is called Global Surgery Modifiers. The other is called Global Surgery Fundamentals. So if you are seeing this rejection, or excuse me, I have to correct myself. If you're seeing this denial, look to those for guidance on global surgery billing. I didn't advertise I'm covering that during today's presentation, only identifying top rejections, denials, how you can avoid them. And these resources that I'm talking about are just two of the multiple resources that will assist you in correct coding and submission of claims for pre and post-op care. The next one, separate payment not made for the service. Do not bill the patient. Over 2,000 denials. This is a situation where you would want to look to the National Correct Coding Initiatives information out on the CMS website, and you're going to look specifically at those procedure to procedure, or what we call PTP, edits. We have some great resources already available for you if you're seeing this kind of denial, and I'll show those to you later on in the presentation. Next one is collection of fee-for-service during periods of managed care. That would be a situation where the patient would have been enrolled in a managed care plan, and the claim should not be processed by WPS, so we're going to deny it. Look at the next one, duplicate charge paid on such and such a day or claim on, well, the claim, and actually that's just kind of a filler here. This question mark with the zeros followed by the 1 and the X's would be an ICN that shows up on your remittance advice. So this is a duplicate charge. Every day we deny scores, scads, hundreds, thousands of claims because they're duplicate. So we want to do everything we can to avoid duplicate submissions to WPS-GHA. If you have a claim that that has multiple lines on it and one line denies and the rest pay, don't submit the entire claim to us. Don't resubmit if it's a situation where you can resubmit. Submit only the service that denied. This avoids this type of denial. Duplicate claims and charges cost everyone money, not just the Medicare program, but for you, your offices too, your provider offices, your clinic, your entities. So we want to reduce the number of duplicate services being submitted to Medicare, and we do have resources available that address this. Next denial is claim must be sent to the EGHP first, and I use this acronym here because this is exactly how it prints out on the remittance advice. EGHP stands for Employer Group Health Program, or plan rather. So this is a case where MSP rules would be in place. You need to send it first to the other insurer. You would look to the MSP resources available that WPS has published on their website, CMS has published. We also have some YouTubes available that will help you avoid those denials. Payment included in another service received on same day. That's a bundling type issue. Look to the NCCI edits. There is another situation for duplicate charges, 599 more. That's a lot of, and that's just general surgery claims within that time period. So think of the number of claims that we're receiving, processing, and denying for duplicate charges. It's very costly. The next one, we can pay only one initial visit per specialty per group. That would be the situation. And a reason why you'll see coming up soon that some of the most commonly denied codes are E&M codes or initial E&M codes. Only one initial visit per specialty per group every 3 years. Denied service or units of service are exceeded. This is the MUEs. That's also part of the National Correct Coding Initiative. So you can look to the medically unlikely edit tables on the CMS website in order to avoid this denial. Time limit for filing your claim is expired. No appeal rights. This is that exception, folks, that I told you about earlier. Most often a claim has a right to an appeal. However, for this, time limit has expired. There is no appeal right. We had 471 claims submitted more than 1 year from the date of service during that time period. So these claims were denied. There is a resource on our website that tells you how you can file for a waiver for that time limit, and I'll point that out to you when I get to those resources. First of all, though, I want to look at those top denials, and there's where you see some of those initial visit codes. In fact, I have one of them twice here, so I'll have to go back and make a correction and send it to you. I'm seeing that I listed 99204 twice. My guess is that I transposed something here, so I apologize for that. I'll fix that and get that out to you following the event. So these are top denials by HCPCS or CPT codes for the 0 to specialty during the time period. I do want to mention to you that, and I touched on this earlier, we can break down the data we're looking at by state, by county, by HCPCS codes, by county, by HCPCS code, and so on and so forth. And we can also look at trending. And I want to show you an example of trending. And keep in mind that this is almost instantaneous with the touch of a button that we can get this. I chose a denial, and the code description for this denial is charges incurred during an incarcerated period. So the beneficiary was incarcerated. Claim count is what shows on our trending report when we pull this data. 59 claims the current 3 months. The 3 months prior, only 8 claims. So the difference in the number of claims from the previous 3 months till now, this 3 months, is 51. That percentage of change is 638%. When we look at this report, one of the things we see are arrows. The arrows point up, and they would be red, or they point down, they would be green. And what this means at a really quick glance, and how I can use this and my team members can use this, people like Aline and all of my other team members, we can look at this and we can very, very quickly see the trending of our rejections and denials. You know, what's increasing, what's decreasing. You know, what do we need to write a news item about? Maybe we need to record a YouTube video. Maybe we need to hold a webinar. So these are just some of the ways we can identify really quickly and easily what we need to provide education on so that we can help our providers and their staff avoid these rejections and denials or correct them. Here are tools, and there are many of them. I mentioned, whoa, sorry about that. I hit my scroll button again. It's a bad habit of mine. Here on this slide, I've linked you to the claim processing guidelines. These are Chapter 26, Publication 100-04. That's the Medicare Claims Processing Manual. That tells you item by item on a paper claim form what you need to place on your claim. Is it required? Is it situational? That is where you will find that great information. So if your claim lacks information needed for adjudication, this could be a good starting point for you. Checking your claim to make certain you have everything on there you need. I want to show you next demonstrate for you where you can find this next document, the CMS 1500 to ANSI 837 5010 crosswork, because this IOM publication data set here, the completing and processing of the form CMS 1500, is a great resource. But what if I submit on an electronic claim, and most of you do? I'm going to show you where you find that and what it looks like, because some people aren't aware of it, and it's one of my favorite things to show because people really uh, take away this resource because they didn't know it existed. So I want to show you where to find that claim crosswalk and explain it to you. If you are on the WPSGA website, over on the right hand side is quick links. One of the quick links is to EDI, which is our electronic data interchange area. If you scroll to the bottom of the page, you will see Medicare, TRICARE, WPS, private or commercial insurance. Of course, what we're talking about today is Medicare, so you would choose Medicare. You can also choose or see the Medicare MAC jurisdictions there, but Medicare EDI is here. And when you move to this page, you can find some of the companion guides. Talked about some of these earlier, that 276, 277 companion guide. I talked about the 999 guide that you see when your claims come in to determine if we accepted your batch of claims. But right now, what I'm talking about is this resource, the 1500 to ANSI 837 5010 crosswalk. So the IOM tells you for each item on a paper claim form what needs to be there. This, I'm going to try to make it bigger for you. This crosswalk says if it's in item 11 on the paper claim form, where do I need to put it on the electronic claim form? What needs to be there? Is it, there's a status column here you can see close to the right, and S means it's situational, and R means that information is required. So this is kind of a crosswalk that shows you for each item on a claim, is it required? What do you need to put in there? Where do you need to put it? And so on and so forth. So this was one of your, I believe, top rejections or denials here. Name of referring provider or other source needed, it would have been a rejection because it wouldn't have been on the claim and it would have been needed. So really, really a helpful tool when you're talking about rejections and denials. So I wanted to show that. All right, let's talk next. Website resource. Here is a resource where all in one place we've created and published a resource that identifies how you correct an unprocessable claim. And remember, unprocessable claim is rejected, and it's listed by remark codes, those remark codes that are maintained by the Washington Publishing Company. So if you get an RA, there's a remark code on it, you don't understand why your claim rejected, you can go out to this resource, find the remark code, and see what it is you need to fix and resubmit. Here are common claim denials. We had the information for rejections on our website. Here's the claim denials. And for our denials, when you look to the website resource, you're going to find them lumped into categories. You know, global surgery rules. This is a category. Here are reason and remark codes that appear on your RA, and this is what you need to do to correct that denial. You can see payer contractor denials, bundling. All of these were, or most of these were those that we talked about earlier today. Here is more website resources or WPS resources. One of the top denials was MSP related, so I included a resource here that speaks to that. I included our live events webpage link where you can find links to our live events, just like the one that you are participating in now. There's our Encore presentations webpage link. I've also included, although this really didn't hit the radar for your specialty, you know, there probably are denials relative to LCD. What I'm talking about here is those types of denials like this service isn't payable for this diagnosis. That would be a LCD or policy related denial. So I included the LCD and article lookup tool. And also a link to the YouTube channel. I talked a lot today about those videos that you can find out on our YouTube channel. Aline put the name of a couple of them in the in the chat so that you can go and find those. All right. More resources, provider enrollment guides and resources. If you have denials related to provider not being eligible, this might be where you want to look. Um, because we process claims based on that primary specialty, we know that provider specialties do sometimes change. So what we want you to do in that case is contact provider enrollment to let them know that you need to update your primary specialty code. There's an MSP fact sheet, and right here is the timely filing of claims. I do want to show you that information because that's one that's been hitting. Let me see. Many of the specialties, I'm doing specialty related education, rejections and denials for many of the specialties, but I do want to show you this because that denial, um, timely filing has been hitting for many specialties. So I want to show that to you. And I'm a searcher, not a navigator. So I like just to search. I use this, put what I'm searching for up in the search box. And right here at the top of the list, I searched for timely filing, and there it is. So this talks about the timely filing of claims, and this is what this hyperlink on your uh, in your handout will link you to. This talks about the timely filing of claims, the fact that they have no appeal rights. This talks a little bit about those situations where the claim wasn't filed timely and it was a third party error, another insurance was involved, they were primary, but they really weren't, and those kind of things. So there's some information there. Potential reasons why we can extend the timely filing limit and how you can file that waiver to extend that timely filing limit. You have to actually submit certain items to the claims manager, and that information is identified here and also where you need to submit it. Now this shows Indiana and Michigan because right now I'm on a jurisdiction 8 Part B website. That's how you can tell here. This is dark blue here, J8 MAC Part B, but I can quickly go to J5 MAC Part B by clicking over here, and then I will have the addresses for my J5 states. Okay, so just a little bit of navigation help there on our website. Okay, move this out of the way. Global surgery coding and billing guidelines is included here. I've also included some information about the modifier 25 fact sheets. All right. Here are CMS websites. The Medicare Coverage Database is a national searchable database that includes all the national and local coverage determinations. Usually each time a policy or coverage determination is published, there's also a companion article. So you can find the articles there too. There is instructions on how to use that searchable database. I've included that link. I've included the Beneficiary Notice Initiatives webpage for those of you that would like to find instructions about the Advanced Beneficiary Notice of Non-Coverage, or the ABN, and use of it, instructions for filling that out. If your claim is going to deny because of medical necessity or frequency, this is where you need to go to find help. So that you will not be held liable for the service. If you properly inform your patient before the service is provided of the likelihood that Medicare is going to deny that is not medically necessary, and the reason why, the specific reason why, then you will not be held liable for that service. And it's a good idea if you have a service that's denied as not medically necessary, when you're requesting your appeal, to include a copy of that BNI, or the ABN rather. I mentioned to you earlier about the trending for incarcerated Medicare beneficiaries. We do see a good share of claims that are denied for this reason. So we have a resource on our website. I've included the link to it here. And then I did it again, folks. I apologize. Going back here. Here's that link to the NCCI. A couple of the rejection or denials for Specialty 02 were due to bundling or units billed in excess of the medically unlikely edits. So I've included the links to those edit tables for you so you can check the procedure code edits. Know if you can append a modifier. Doesn't mean append it, it means go to your documentation and check to see if a modifier may be reported in order to unbundle the service. Or here, the medically unlikely edit files tell you the maximum units of service that can be billed on one day. Here is resources relative to the IVR. You can use the IVR to check eligibility, claim status, and details. Of course, it is a self-service tool. You would use voice or telephone keypad for using it. And if you need instructions, I've provided the link to the guide for you. Similarly, the portal is also available 24 hours a day, 7 days a week. Both the IVR and the portal have limited functionality outside of normal business hours. That's needed because there's updates and such going on in the background in the not normal business hours, so they aren't available. There is some limited functionalities. You can log into this portal to check eligibility, claim status, claim details, and claim actions. And when you're looking at claim details in the portal, and you do need to register to use it, it is a secure portal. You can look at your claim line and click on I believe it appears in blue, at least it does now, or it did. There's a button that's labeled More Info. So let's say your claim denies because of medical necessity. Medical necessity kind of equates to policy. Okay, policies equal edits. There's edits in the system. Let's say it's a frequency denial. If your claim denied due to a frequency denial or a not medically necessary denial, and that more button or more info button is there, you click on it, more than likely what's going to show up when you click more info is that policy. The reason for the denial. So it's a great tool to use to find details about why your claim denied. We do have that portal user manual. If you are out on the WPS-GHA website, you can easily click to the portal user manual on any page. It's right here. Portal user manual. I've included the link for that right here in your handout. All right. Just a reminder, use of self-service tools is the fastest way to fix something, to fix a claim or to request an appeal. All right, we do have just a little bit of time left for questions. Aline, would you please let me know if there's questions that I might be able to answer?
Sure, Mary, thanks. That was great information, and we do have a couple questions. And the first one says, if multiple dates of service are billed on one claim and one date denies, you're saying only to rebill the denied date of service. In the past, Medicare has done a takeback of the other paid dates, thinking the whole claim is corrected. Can you speak to that?
I can speak to that, and I can tell you that in this situation, what I would need to do is to look at the claim itself to respond. In some situations, you may be able to add a modifier that will make the multiple dates of service, one day denies. I would need to look at the ICN to give proper advice on this one, just to make certain that I'm understanding. So Mary, I see that you, Mary, and last initial K, I see that you submitted the question. Could you, actually we'll have it in the chat. I'll respond to that either directly to you, Mary, or to everyone. But what I would like you to do, Mary, is send me an ICN so that I can look specifically at this, I think it's a denial. Yes, denial, and give you proper advice.
Okay, great. Another question came in that says, can you appeal if your quantity goes over the MUE?
Yes, you can appeal denied services based on MUE. What you'll need to do is request an appeal and provide the documentation that shows that the additional units of service were indeed medically necessary, and you can ask for an appeal and we will consider that. Now, we may decide, let's say you submitted 10 units of service. The MUE is 6. That means there's four that are over the MUE. Now, we might pay one of four. We could pay two, three, or four. It doesn't mean we're going to pay all of them, but we may pay all of them. But yes, you can appeal a claim that's denied for an MUE denial. Most of them. You need to look to the indicator on the actual edit tables because some of them are an absolute denial. Those that CMS is not going to pay any additional no matter what. And I would need to go to that to them to see specifically which indicator it is.
Great, thank you. That was very helpful. We just got another question from Kelly. She says, we are seeing denials for surgical procedures with a modifier 52. All components of the procedure code were not completed, and the MAC is telling us to use an unlisted code because we can't report surgical codes with a modifier 52 when anesthesia is used.
All right. Well, I don't know the specific answer to this. It wasn't one that hit the most common denials, but I'll tell you what I would do, and I'll show you. I would begin by looking at the modifier fact sheets. And actually, I think I put fact sheet in there. I'm just going to go to the modifier site, and I can back up. For those of you that do navigate, and you're looking for modifier information, go to Topic Center, go to Claims, and down here should be modifiers, right here. So if you open up the modifiers page, this is where you'll find links to all of those modifiers. What I would do for this particular one, and it looks like it's a specific, claim specific question. So I don't know without looking at an ICN. Here's the modifier 52 fact sheet, and this is going to tell you appropriate use and inappropriate use. What you're saying is all components of your procedure code were not reported. So this is a reduced service reports a partially reduced or eliminated service or procedure code, but you're really not rendering that procedure if you're not doing all the components of it. That's why they're telling you to use an NOC code. Okay. Partially reduced or eliminated service or procedure. So these show appropriate uses and inappropriate uses, but the NOC code is used because you're not doing all of the components of that procedure code. It doesn't mean that you reduce the components of the procedure codes. You're not doing some of them. So I would look to 52 modifier fact sheet in order to get advice for that. But it looks like that one, they're asking you to use an NOC code. So that's exactly what I would do. I did go just a bit over. I apologize for that. I just want to share with you our greatest compliment is when you recommend our education to others. Please consider doing so, whether it's within your organization or externally as you're talking to people, maybe at some society and association meetings. We would really appreciate that. We want to make certain that our education reaches everyone in our jurisdictions. So on behalf of myself and Aline and the entire provider outreach and education team, I want to thank you for your participation. We look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everybody.